Hello, and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, Delivering Disaster Behavioral Health Care, Addressing the Functional Needs of Survivors in Shelters and Other Acute Response Settings. Our objectives today are to identify vulnerable and at-risk population groups that access general and mass care shelters during a disaster, describe crisis intervention, crisis response strategies for working with high-risk populations during a disaster, discuss community resources and referral linkages to assist people with functional needs during post-disaster events, and to identify 3 strategies that responders can use to be personally and professionally prepared for crisis events. If you have a question about anything being discussed today, please call or email our faculty presenters during our live broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses, social workers, and emergency responders for today's program. The Alabama Department of Public Health is an approved provider of continuing nursing education by the Alabama State Nurses Association. The association is an accredited approver of continuing nursing education by the American Nurses Credentialing Center's Commission on Accreditation. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. Instructions on how to do this can be found at the bottom of the sign-in sheet. While content may continue to be relevant, CE credit will only be awarded for 2 years from today's date, which is May the 21st, 2014. There is no financial relationship between the planners of this program and the speakers. There is also no commercial support for this program. Alabama Department of Public Health does not endorse any product that may be displayed in conjunction with any activity that might be demonstrated, nor will the department discuss any off-label use of products. As a reminder, the content of this program is based on the policies and procedures of the Alabama Department of Public Health, Alabama and federal statutes, rules, regulations, and guidelines. Viewers not employed by the Alabama Department of Public Health should always check to clarify whether the content is accurate according to the statutes, regulations, policies of your respective jurisdiction or agency. My name is Elena Parker Merriweather. I work in the Center for Emergency Preparedness as the Minority and Special Populations Coordinator and State Medical Reserve Corps Coordinator. One of my roles is to coordinate disaster preparedness trainings and conferences for healthcare providers. Our goal is to raise awareness around the needs of minority individuals and at-risk and vulnerable population groups during an emergency or disaster. Today's satellite conference has been planned with this goal in mind. I would like to introduce to you our first speaker, Dr. Anthony Spire, retired Assistant Secretary from the Louisiana Office of Behavioral Health, Department of Health and Hospitals. And we also have Ms. Linda Lagenza, Clinical Services Director from the National Council for Behavioral Health. Dr. Spire, tell us about disaster foundations and how to identify individuals with functional access needs.
All right, thank you very much.
You're welcome.
In your slide deck, you'll find, if you download it, there are a good number of slides. There are a number of slides that we will just briefly touch on throughout this process, and we'll refer you to the content in your actual slide deck for you to look at a later point in time. One of the more important things we felt, Linda and I, in preparing this workshop was that we would provide you with a lot of current content information and do it in a way that this presentation would highlight the more pertinent points so you can then go back and look at the slide themselves. The course outline is done into 5 different parts. The first being the context of care, and this will give you information on how an actual concepts of disasters are organized. Then the facts or key concepts of disasters will be our part 2. The vulnerable populations are part 3. We'll take a break somewhere in there, I think after part 2. And then, thank you. And then the last 2 sections are part 4, which is really what you need to do. What are the aspects of how you will deliver care? And then the last part, of course, is staff preparation. How well will you do caring for yourself? You can't really give good care if you are all stressed out yourself. So we'll take a lot of effort to close up with that piece. In the first section on the context of care, just some definitional phrases to keep in mind. There'll be just a few of these. Disaster is a natural or human-caused occurrence that causes human suffering. And the takeaway here is the term human suffering. And you can see the great diversity of the types of disasters that we're speaking of. The next is the definition of a disaster that creates collective need that overwhelms local resources and requires additional assistance. Now, one of the things that's really important to remember in the United States, the way we think about disasters is that the person or the individual community themselves should handle that disaster and then only ask for need when it exceeds their capabilities. And that's where these definitions come from. The last being in the Stafford Act, and the point of that one is that under certain circumstances, the president can declare an area a disaster, and once he does that, it brings into play the Robert T. Stafford Disaster Act, which then allows communities and states to benefit from federal assistance. We took the week of October 13th. October 20th of 2013, just as a sample of the kinds of disasters that you see all over the world in a given week. And this week, an earthquake, a typhoon, a polio outbreak in Ethiopia. Disasters are everywhere and happen with growing frequency in both the technological areas and in the natural areas, such as floods. You can see up here the technological ones, the road accident in Nigeria, a plane accident near an area of Belgium. They happen, if you take your own newspaper this morning and look at it, you'll see huge gas lines that have exploded. You'll see mining accidents. You'll see floods. You'll see the ongoing drought in the western United States. The economic impact is huge. As you can see, that China, United States, the Philippines, and India and Indonesia are some of your major areas where disasters typically happen. And Superstorm Sandy, which hit the East Coast last year, is, again, a huge dollar amount of loss of $50 billion. So huge impact, huge economic impact. So the psychological impact is the coping with loss and grief, the strong emotional reactions people have, the possible exacerbation of pre-existing conditions, both physical and psychological, the difficulty making decisions, and knowing that people can and do actually recover. So when you go through this process of planning for a disaster, you need to keep in mind that people are impacted no matter what. You know, anyone who tells you they're not impacted is having an impact by telling you they're not impacted. So we'll talk more about that as we get into our second area. Linda, you tell me when you need to take over. Okay. Sure. The pre- and post-disaster planning efforts, the impact and evacuation area, immediate response, location, sheltering, outreach, family assistance centers. These are all areas of where disaster response occur. In the immediate response, the disaster recovery centers, individuals who are building resilience, and then the recovery area, areas of community resilience and treatment services are areas that we are concerned with. Now, in pre-incident planning, this is an area of where The behavioral health preparedness plans at both local, regional, and state levels are really important, and they all work in sequence with each other. So if you're not familiar with your local area's plans or that of your local clinic, ask the people who are in charge. It's really important in planning to have partnerships, both public and private, have ongoing staff training. And just something I always ask people is, do you have a generator at home? Have you started your generator on a monthly basis? Do you have gasoline for your generator? Do you have all those things for yourself? The same thing happens also at work. So in the staff training, having call trees and work assignments pre-identified for people, having the job functions and initial assignments laid out so people know where they're going is really important. Establishing and maintaining a volunteer cadre of people to provide disaster mental health services is something that has to be renewed on a regular basis. People's skills need to be freshened. People are at different places in life where they may or may not be able to continue to provide that service. So you have to always freshen that volunteer cadre up. And then the communication networks and media shelf kits. One of the most obvious examples of that was following the avian flu that was going around a few years ago, having shelf kits that could be PSAs or public service announcements that would help people deal with the fact that people were getting scared that they all needed to go to the hospital when that in fact was not the case. The typical planners in emergency management are the public health agencies like Office of Public Health, mental health, substance abuse agencies, various first response agencies, and local mental health authorities, and the behavioral health provider community is a big partner in that process. American Red Cross and local Red Cross entities and volunteer agencies or organizations active in disasters, peer and family groups, especially for people who have disabilities and chronic conditions, they'll need assistance, are really important, as are consumers of various public sector services and their caregivers. In behavioral health planning, community planning, it's important that all levels are involved. So being involved in these exercises, educate and train and internal, external responders is important, and then partnerships with the federal agencies as well. It's really important that you include those federal partners in the training and your professional organizations. If you don't, then when it's time for a disaster response, people don't know each other, and it's much more difficult for them to do well in carrying out their responsibilities. So again, several levels of planning are important, and it's really important to assist people with behavioral health needs in the planning process as well. So personal planning realities. This is true of all of us, and I would copy down this slide and take it home, and I'd take it to work and post it up everywhere. People will not plan for their personal evacuation. That's helpers and people who are survivors. Having a family or personal evacuation plan is not easily accomplished. You have to really work on that with your family, especially if you have small children. People are worn out by the time an incident happens, and people need structure and leadership in order to facilitate recovery. So having planning allows that to happen. And people also need to plan for their pets. It's incredibly important. Your pets are to people, and if you don't plan for them, really difficult things happen, as we've seen in previous examples. The little items up here, rescue alert stickers can be put on your windows to let, in case you were to have a fire in your house, that there are animals in the house. Always arrange a safe haven for your pets, and this is really important on the emergency supplies if you have to evacuate. Okay. All right, and then so the assessment of disaster impact is across these different areas: pre-incident warning, the duration, intensity of the incident, displacement loss, and loss of human capital. These are all things we're going to go into in much more detail. The assessment of needs and resources. There's a viability of the existing infrastructure. Is it still intact? Do you have all the various levels of response that you need? Do they continue to remain in an operational status? Is there a continuity of operations? If your systems went down where you work, would you lose all your data everywhere? Has that all been backed up? Could you send, if you're seeing clients, could you send them to another location immediately, or would all their records be lost? So you have to match recovery needs with resource needs. So that is a very important matching and sequencing that's important. And then the sustainability of the new services. Sometimes you can just put interim services in place that are only going to be good for a few days. So I'm going to stop my part, and Linda?
Sure. So as we continue here to lay out the foundation for you, we wanted to move into primarily sheltering operations, because this is, of course, where most of the work is going to take place. And sheltering starts with mass care services. And mass care services are actually set up to minimize the immediate disaster-related suffering on the part of the people who are involved in the disaster. And typically this involves the provision of food, clothing, shelters, and supplies. And in mass care services are included medications, medical equipment, distribution of emergency supplies, such as methadone. We saw after Katrina in Louisiana, and Tony knows this best, that there was a shortage of methadone, and that was a huge problem in the shelter. So these are things that planners need to be thinking about and planning for. So it's the other areas of mass care services include family reunification, the focus on medical, behavioral health, spiritual care, and of course resources. So mass care services basically focuses on the physical, emotional, and functional needs. In emergency shelter programs, I wanted to take a look at the definition here by the Americans with Disabilities Act, because it's really important to note that regardless of who's setting up the shelter, and that could be the American Red Cross, it could be one of the voluntary agencies, every single person is entitled to the same resources. And those include safety, comfort, food, medical care, support of family and friends. So no one should be turned away from a shelter because of some type of disability or some type of need that they may have. There should be really no wrong door. So when we talk about mass care sheltering, we're talking about basically two types of shelters: general population shelters, which we're going to talk about now, and medical special needs shelters. So in terms of general population shelters, of course, these are what we typically see. Usually it's the Red Cross who sets those up. Maybe at times it's faith-based organizations. But basically they're set up to really provide care to those who need it after, who are impacted seriously by the disaster. And as I mentioned earlier, they're there to support people in terms of their basic needs: food, water, medical first aid, and in most cases, psychological first aid as well. So it's important also to think about functional needs support services, FNSS. In general population shelters, there really must be a need to meet those functional needs of all those folks who are in the shelter. As I mentioned, no one should be turned away. So even if someone has an existing difficulty, disability, there should be an effort made to help people to function within those shelters, and as much as possible to help them maintain their independence. What services, supports may be needed to allow someone to remain in a general population shelter. And we're referring here to both adults and children. And those areas include physical, medical needs, sensory needs, those folks who have hearing or visual problems, of course mental health, substance abuse issues, and cognitive issues as well. And those would include people with dementia, perhaps people with developmental disabilities. So when we're talking about functional needs support services, we're really talking here about exercising flexibility and doing our best to really respond to the needs of the folks who happen to be within that shelter situation. And that may mean acquiring medical equipment, utilizing personnel even to assist someone in case they don't have a caregiver present. The aim is to have caregivers present for people who need that, but of course that doesn't always happen, and so that may be something that needs to be set up for someone. So now we're moving into medical special needs shelters. We just talked about general population shelters, but in terms of medical special needs shelters, these are also congregate facilities, and they're for individuals who may require assistance to manage their medical needs. So they won't benefit from having assistance to help them within the general shelter. They actually need more services, more help than that, and therefore would require a special needs shelter. So as I mentioned a moment ago, actually in medical special needs shelters, generally there may be a caregiver there, but in certain circumstances they may need to have someone assigned to them. Medical special needs shelters are only temporary, as is the case for all shelters. These are set up as temporary responses to the disaster. But they may include medical monitoring and limited medical care. Of course, if somebody needed much more intensive medical care, they would have to be referred to an emergency room, a hospital, maybe a nursing home facility. But they would be taken care of in this way until the emergency passes. Common state roles and responsibilities. It is the role of the state to really oversee and monitor medical special needs shelters, and particularly in the area of medical needs, and the state is actually the entity that will determine the need for medical special needs shelters and will also determine when those shelters discontinue services. And some of those services include supplies, equipment. They oversee the discharge of folks within that medical special needs shelter. It could include also monitoring ambulance transportation and opening responsibility for determining when to close the medical special needs shelter. So we have a situation, an example that Tony is very familiar with, and that is the Louisiana Department of Health and Hospitals. And in that situation, the state coordinated medical care. They were responsible for coordinating all of the medical care, both in natural and man-made disasters, such as the oil spill. And they do this actually before a disaster occurs, during the time of the disaster, and after the disaster. And coordination of medical care and services occurs at all of these levels. Includes medical special needs shelters, emergency operations centers, medical evacuation, dispensing sites, search and rescue, temporary staging areas. We saw in Louisiana that they used I-10 as a staging area in the beginning of the disaster.
Yeah, following Katrina, we had to use the actual interstate as a landing and assessment area, and under this, that would be both the transportation triage and medical evaluation component before people went on to other more stable sources of health care available.
Yeah, so there we see an example of how the state oversaw the triage and medical and other services that were needed. So you know, we wanted to share with you the basic services that individuals and communities really need after a disaster. And one of the things that's important here is to mention that, you know, before the Oklahoma City bombing and before 9/11 and Katrina, there really wasn't the involvement of behavioral health in disaster planning or disaster response for that matter. It was really after those very serious, severe disasters that much more research took place, and we started to figure out that people are really impacted emotionally by disasters. And therefore, we need to focus on areas like crisis response, managing stress, not waiting for people to come into a mental health facility, but actually doing outreach to the people who are most affected, and using interventions that are consistent with the phase of the disaster and exposure. And the definition of disaster behavioral health is that it is the provision of mental health, substance abuse, and stress management services to disaster survivors as well as responders. We know that responders are just as much at risk for adverse reactions as the people who are, you know, the survivors of the disaster. And in some cases, responders are also survivors of that same disaster. So we really need to pay attention not only to the survivors, but also to the first responders. And when we talk about first responders, we're not just talking about emergency management, but we're also talking about behavioral health responders. We're talking about shelter staff as well. And so the role of behavioral health providers is to care for people with pre-existing mental health or addiction issues. And in some cases, they're their own clients, their own population who's served by their organization. But not just that, but there's going to be people who are coming into the shelter who are going to be affected by that disaster and who may exhibit some serious reactions to the trauma that they experienced. Behavioral health providers also need to pay attention, as I mentioned, to first responders as well as to their own staff and shelter staff. And so common behavioral health responsibilities include triage and assessment, crisis intervention, and ongoing behavioral health services. And what we see in medical special needs shelters is generally there is a licensed mental health professional who is on call or on site and to provide that behavioral health intervention. There's also access to 24-hour on-call psychiatrists to provide consultation to shelter staff, and consultation around methadone treatment and access to developmental disability services. I mentioned a moment ago methadone. That could be a very serious issue for people who don't have access to methadone because they may have left their home and not taken it with them, or it's dispensed you know, on a daily basis. So this is something that, as I mentioned earlier, really needs to be considered.
Excuse me for a second, Linda, if I could interject and ask this question. As it relates to methadone, could you give some examples of situations that have occurred in the shelters where methadone has actually been an issue?
I know Tony had a lot of experience with this.
Well, we had a lot of people who, there are 8 methadone authorized providers in Louisiana at various locations in the state. So in the sheltering, when you have such a mass exodus of people from their normal supply to methadone, you have people in need, so, and no supply chain in place. So it's really important that with your Office of Addictive Services that be worked out as to how you would have methadone legally available and would meet all the requirements of a methadone dispensement site. And there's some good guidance on that now available through SAMHSA of how to proceed with that process.
So some of the responsibilities of behavioral health staff in shelter situations include on-site behavioral health interventions such as dispensing medications, providing crisis intervention, and support, stabilization, also helping people transition perhaps to medical special needs shelters if that's indicated through triage and assessment, and providing support and promoting resilience in the form of psychological first aid. I think at this point many people have had training, particularly here in Alabama, which is really fantastic, on psychological first aid. And we'll be talking a little bit more about that a little later on. Some of the other responsibilities include observing. It's really important to have people, behavioral health folks, doing surveillance in a shelter situation so that you're noticing what's happening with folks and you're looking for any signs of agitation, confusion, shock, depression, substance abuse issues, and you're providing assessment on an immediate basis if that's necessary, and also assisting medical special needs shelter staff with psychological and addiction medications in order to reduce the risk of any kind of behavioral reactions. Behavioral health responsibilities also include assisting staff with in setting up activities for adults and children to reduce stress. And I remember after 9/11 being in the Family Assistance Center, and there was just such a huge outpouring from the community. So people were coming in from all over to volunteer their services. And this is what happens really in all disasters. It's, you know, it really, sometimes disasters occur because of people who, you know, have some problems and may do some bad things, but disasters also bring out the very best in people. And so I remember volunteers coming in to set up areas for children in particular, and bringing in all kinds of activities and toys and games to keep kids occupied. And it's also important to do this similar, have a similar situation for adults as well, so that they're not getting completely stressed out and you know, start to exhibit some behavioral issues. Debriefings are also important for all the staff who are involved in working with the survivors. It's very stressful work. It's very sad and emotional work. And so, again, I remember working very closely with the American Red Cross. They determined that they would be the folks who would handle the debriefings. Because all of us, the state folks, which I was one at the time, the local folks, all the volunteers, were involved in the actual face-to-face work. And so it was actually helpful for some of the folks from American Red Cross to handle those debriefings before and after people left for either coming onto their shift or leaving for their shift. It's and in that situation, you know, people were involved in the staff were going over lists of survivors, and there were very few survivors on those lists, and it was extremely painful and emotional work to sit there across from a family member and talk to them about their family member not being on that list. Having to collect DNA samples, extremely stressful as well. And so the idea of doing debriefing with staff, particularly at the end of their shift, is very important to helping them with their self-care and taking care of them, and also making sure that people don't work too many hours, making sure that they take breaks. Other behavioral health responsibilities, helping to de-escalate people who might be observed having signs of distress, and providing just-in-time orientation and training to the staff involved in the shelter operations, particularly focused on psychological first aid techniques. And what do the shelter staff need in order to be prepared? Of course, they need to be trained to recognize serious mental illness, signs of distress. They need to have mechanisms to screen for suicidal behavior or ideations, alcohol use or abuse, violence. They also need to be able to recognize their own limitations and know when they need to really get support from the behavioral health staff. And in order to prepare shelter staff and to do their job most effectively, they really need to have superiors within that shelter operation that can give reassurance, that can ensure that there's relief, provide structure, a buddy system. Of course, they need to be valued and respected for the work that they're doing, and in some cases recognized. And as we mentioned earlier, to ensure that there are debriefings and stress managers going around the shelter in order to check in with people to see how they're doing. And the needs of evacuees in shelter situations. And here we're moving into the area of promoting resilience. We want to begin to promote resilience in the people who are affected by a disaster the moment we encounter them, from the very first encounter. So we have to know what those psychological first aid techniques are and what really helps to promote resilience and recovery after a disaster, because those encounters are really very significant and can make a significant difference in that person's recovery. So how you come across and what you do in those moments is really critical. And of course, you know, what's important is working from a strengths-based approach. Empowerment is extremely important. Trauma, disaster trauma, is all about loss. And, you know, we need to empower people to help them to gain, to regain their, you know, their control and take charge of the situation. There also needs to be pre-planning in terms of protocols for how to manage behavioral disruptions within a shelter situation. There needs to be sufficient staff available to manage. They need to understand the 5 key elements of building resilience. And these are the elements that are really included in psychological first aid, like safety, comfort, self-efficacy, you know, which is really empowering people. Connectedness. Connectedness, we know from the literature, from the research, is one of the most important ways for people to build resilience and to recover from a disaster. I actually had the privilege of hearing one of the family members, the mom of a child who died in Sandy Hook in Connecticut, the school shooting. And she talked about how important it was to her to have family and neighbors come to assist them after this tragedy. People sent things like blankets and teddy bears, and she didn't mean to be disrespectful at all, but she felt that sending a pink blanket was really a trigger for the trauma that she had experienced, and that was not really so helpful. But having her neighbors come and bring in food, noticed that her doorbell had stopped working, and they knew that people were coming in and out, and somebody took charge of taking care of that, really meant so much to her in her recovery process. And we know that. We know the letters that come in, the outpouring, the candlelight vigils that occur. You know, communities coming together is what really helps people to start to rebuild their lives. It's all about community, really. And wanted to talk a little bit about the American Red Cross and what they talk about as the elements of disaster mental health response. And they talk about the continuum of services, care and services. And, you know, that's what we've been talking about, really. It starts with triage. It includes mental health surveillance, which we were talking about, and it also includes some targeted interventions that are appropriate to either the survivors or the workers in the disaster setting. The continuum of services includes identifying mental health and substance abuse needs through triage, assessment, and observation. It also includes interactions and interventions that promote resilience and using psychological first aid techniques. And it also includes using targeted interventions such as calming techniques, de-escalation, stress management, referrals. Referrals are extremely important. People may need those, and you need to know what resources are available. Crisis intervention. Some people in the shelter situation or after a disaster may have lost loved ones, or they may have sustained injuries, and grief counseling may be really critical as well. You have all of these slides at your disposal, and we don't have time to go through all of them, but we were glad to be able to provide them to you. The American Red Cross also talks about their crisis intervention model, and of course it really begins with providing support, reassurance, and of course looking for signs of shock, psychosis perhaps, extreme fear, anxiety, always approaching people with a calming presence. People are not able really to respond to you or to handle a disaster or trauma situation, and they're not going to be able to really lower their anxiety unless you provide some calming and you help them to calm themselves as well. So really knowing how to do that is critical. And also being focused, directive, really helps people to be able to calm themselves, and also reassurance is very helpful. And asking about and addressing any feelings, emotions that people are experiencing. For example, talking about, you know, people may have just experienced some horrific tornado, and now they're sitting in the shelter, but they're kind of re-experiencing that. It's important to even just remind them in a calm way that that's over. That tornado is over. They're in a safe place, and you know, and they can start to relax at that point. It's also important to be curious about in asking people what's going on and how can we help them prioritize the experience that they're having, and exploring what has worked for them in the past in terms of coping, identifying solutions that may be helpful to them, not really focusing on the problem so much, but how can we move ahead? How can we help you here? What resources can we connect this person with? Helping them to develop a plan and follow up with that plan. Following up may also include giving that person some assignments, or that person determining what assignments they're going to have, and then coming back to you to share how it went, what they were able to accomplish. Could be really helpful to folks. We also wanted to identify those folks who are in shelter situations who are most at risk. And the populations of people involved include children, frail elderly, persons with psychiatric disorders, substance abuse disorders, and certainly people with other disabilities, physical disabilities, cognitive disabilities, including dementia. It's also important to consider cultural identities and factors associated with culture, and factors that are. These are some of the factors that are related to risk of adverse reactions as well as protective factors. So in terms of risk, there may be someone, family roles are important because, for example, a single mom who has a couple of children is going to be much more at risk for having adverse reactions, particularly if she doesn't have the kind of supports that are needed to respond to those adverse experiences. On the other hand, protective factors may include having strong faith and support from people from their church. So actually, I am going to stop there, and we're going to take a break.
Yes, we can go ahead and transition into our break, and we will start back up within the next 10 minutes. Welcome back to the second half of our satellite program, Delivering Disaster Behavioral Health Care. In the first part of our program, we talked a lot about different aspects of response as it relates to disasters and working with special needs and functional access needs population groups that are a part of mass care shelters as well as medical needs shelters. One component of that discussion brought about some thoughts around methadone issues and how people who have been involved with methadone use are impacted in a shelter. And we had a question from one of our nurses that we wanted to give her the opportunity to ask our presenters.
Yes, I would like to ask the panel in reference to a client that may come into your medical needs shelter and bring their own supply of methadone with them. Do you allow them to continue to self-medicate, or do you take that methadone and count it and dispense it as needed? Or what are your thoughts on that? We've gone both ways, and I'm just interested to see what you might think about that scenario.
Just to repeat your question, the gist of it, as I appreciate it, is someone comes to the shelter, they have their own supply of methadone. Do you let them self-administer, or do you take it from them?
Correct.
And that could be answered in lots of different ways. So it's a wonderful pre-planning initiative. Mm-hmm. There's certain issues for methadone regulation and for a registry of who is on methadone in your state, things like that. So those have to be taken into account. Then also there has to be, by your state agency, a process of how you will have your policy on self, it could be in certain circumstances you would do a self-medicating program. It might be in other circumstances you would not want to do that. Mm-hmm. So in different kinds of sheltering situations, that would be applicable. In our state of Louisiana, we used for addiction services and their clients, we often used treatment sites for sheltering, for evacuation. And so you'd have a whole different kind of application there of your sheltering process and medication issues. So I would encourage you all to raise that as a training and exercise question. And I think it will uncover for you some unintended consequences of going one way or the other on that, as you can well imagine.
Mm-hmm. Thank you.
Thanks, Teresa. Are there other questions? Okay, we'd like to go ahead and transition into part 2, key concepts of disasters, phases, risk factors, impact, and reactions. Tell us a little bit more about that.
Okay, Elena, this part is very interesting. It's actually one of my favorite areas of training, and that you really get a chance now to think about how the reactions people are having are impacting their lives and what we can do about it. Really, the rest of our presentation will talk a lot about how you will find treatment models that work most effectively with different groups. So again, in this group we have a bunch of slides, and I won't spend a lot of time on all of them, but would encourage questions you may have, and we'll answer at the end. In this particular slide, which if you looked at any of the disaster literature, is what we call kind of a non-scientific heuristic device of where it plots the particular kind of reactions people have in different phases of a disaster. And if you look at just the major tidal areas, pre-disaster, which is the preparation, warning and threat stage, and then on through the process, you see various reactions people have. There are some basic key concepts behind this on the positive side. And going to the next slide, everyone who experiences a disaster is affected by it in some way. So in your work or in your role as a parent or a caregiver, know that. And that will temper how you respond to people. People pull together during and after a disaster. If you query your emergency department people, you'll find there are probably more heart attacks and injuries from chainsaws and lifting things than there are from the actual disaster itself, because people are highly energized and all of a sudden go beyond their normal limits on trying to help their neighbors.
Tony, if I could ask a question. Oftentimes when we talk about caregivers as well as volunteers, the common response is, what do you need? What can I do to help? Is it common for people to not know what they need after a disaster?
That's a really good question. And the answer is yes, people don't know what they need. You're really responding to, a lot of times, just that sense of being overwhelmed. So as you'll see as we go through this presentation, Elena, there are some areas of where, and as Linda's pointed out earlier, of just if any time you address people's basic needs, you're doing the right thing. So, you know, a little soft toy that maybe this family next to you lost theirs and they have little kids, and little soft toys would be good for them. Just some very basic things like that.
Okay, thank you. Oh, Aquanetta?
I just had a question for both of you in reference to the graph that you just presented. Have you noticed differences between natural and human-made disasters relative to the graph? And the reason I asked that is because in Alabama, following the oil spill, we kind of felt that this really wasn't appropriate for where people were. But just curious to see if you've noted any differences with that.
One point I would make, and Tony is, has done so much work in the area of the oil spill, so I certainly want to give him time to speak. But one of the things that happened with the oil spill is, and happens sometimes in certain disasters, is this was a prolonged technological disaster. Prolonged. It was unfolding for many weeks and months. And so with no stopping, no end in sight, that's going to change this whole graph. and the process that people are going to go through. There's going to be a prolonged period of heightened anxiety and fear and worry because of the unknown. They don't know what to expect. And they're in this state of, not knowing what, what they're, what they are looking at in terms of a future. So I think that's certainly one response to your question.
And thank you, Linda. That is very right on from our experience on the oil spill. There's some prior history with the leak out of the Exxon Valdez ship in Alaska, and one of your one of your Alabama researchers, Stephen Peek, who did a lot of work in that disaster, and one of the things that he noted was the concept of the community toxicity, meaning the delayed resolution of claims people have, the delayed resolution of the of the environmental recovery, creates that area of uncertainty. So in this particular graph where you see the disillusionment phase, you'll see that start to change a lot. And right now, the different states that are impacted are looking into those kinds of things. So I think you'll see some informed information that will help in future technological disasters on that point. Okay. Anything? Okay. Staying with the same graphic, you'll see that even though people do pull together, that everybody has a stress reaction, and that these reactions are varied, and you'll see in the next few slides how varied they can be, because many people, and you could figure in the neighborhood 70 to 80% of people do have a natural resilience that they will recover without additional behavioral health services. Psychological first aid, just knowing that you're safe and connected with people, again, maybe all the vast majority of people need. This particular slide here on Maslow's hierarchy is often used as a way of looking at the basic needs people have. In this, I don't know if you can see it well on the presentation you're viewing it through, but at the very bottom of the slide are the physiological and safety needs. And if people are not, if they're hungry and cold and are without sleep and they don't feel safe, ask them to think about ideal or areas of esteem, or how do they think and feel about the disaster in some esoteric sense. Is it where they're at? They really need those basic needs met, and that's the main point in Maslow's work. If you don't satisfy these basic needs, then trying to talk on a level about other kinds of issues really is not successful with people. So the high-risk events that cause reactions that people have that they sometimes cannot manage without additional assistance is the disruptive process of evacuation. Was it a planned evacuation, or was it all of a sudden brought upon you, and it is have to be carried out in maybe a life-threatening arena? Ending search and rescue processes, when you finish that process and you quit looking for people who are alive and move into recovery operations, it's very stressful on people. Death notification process, which American Red Cross in many disasters does a lot of that, but there's from Linda's mentioning of the 9/11 experience and our experiences in the Hurricane Katrina and in all of our states, emphasize the importance of how difficult that is. Funerals and memories, a lot of work has been done on that. I encourage you to look at how people make things like memory boxes and things that are able to help people process loss while maintaining the integrity of their memories about people. And then the reopening of public sites. We have the 9/11 happening this week. And that, again, triggered so many feelings for people. And again, you have that on the various anniversary dates of a event. The other risk factors across many different disasters are issues of race and poverty, ethnicity, age, unemployment, gender, and previous exposure to trauma, and being homeless. And we'll be talking about that Linda will in another section in a little bit. The population exposure model I won't spend a lot of time on, but basically what this is just saying is the more closely or the greater the intensity of the impact from where you are and where the actual disaster is, usually has a profound effect on your ability to process information and recover. And again, type of exposure, the degree of exposure, and the proximity to the event are what really impact a lot of recovery. Let's see, the physical integrity of oneself and others, threats to that, where you feel like your life is threatened, have tremendous impact, and a lot of trauma work is done around that particular kind of event people experience. Okay, the disaster impact itself, some people, as I've mentioned, will have severe reactions. Few will develop diagnosable conditions, and most do not seek help or treatment. And survivors often reject help, and most will be resilient but may need assistance. So these particular impacts, I want you to save this slide and reference back to it as we go into some of the other sections, because talking about how to deal with these common factors that are on this slide will be, I think, very helpful for you. The typical stress reactions, everybody will experience shock to some degree or confusion. The resilience that one has as a natural-born feature will help some people process that information more successfully than others. But, you know, sometimes I often think of the people who are the checkout counters at Walmart as some of the best counselors after a disaster, because they give an opportunity for a person to talk about what their experience has been. And they're probably some of the best counselors we have about. Difficult in concentrating is another sign of a significant stress reaction, as is the reintroduction or giving up abstinence and starting to use substances again, that kind of thing. Okay, so there are the individual level reaction, which we've been spending time on, and then there's a collective or community reaction. And the community reaction affects the individual coping and also may damage community support. A term some of you may be familiar with is that of social capital and community efficacy. Those are areas that I would ask you to look at in the literature if you want to know more about this particular model that's out that we're suggesting you find out more about. Hey, your typical reactions, everybody has physical, emotional, cognitive, behavioral, and spiritual reactions to everything in life. And what we're talking about here is how stress, abnormal stress reactions manifest themselves in each of these dimensions. In the physical reaction, you'll see people have changes in weight. They will experience temperature differently, may have gastrointestinal problems or headaches. There'll just be a change in physical awareness. Important thing is the clumsiness you'll see on this slide is people get hurt because of the stress, and they are more clumsy. They trip, they fall, they break hips, and those are things that to be very sensitive to. Then the issues like chronic fatigue or sleep disturbance. I recall at a particular event where a school was damaged by a tornado. The principal was taking care of everybody else. He hadn't slept in 3 or 4 days. He was getting his school back together. And this was a very sad situation where it was a small school and the homecoming queen was killed in the tornado a week after the prom and at their homecoming. And he was very distressed. He could not really recognize his own distress. And I went to go with him to go someplace down the road, and his truck had all the windows blown out by the tornado, and all the glass was still in the truck. So he could not even see to take care of getting the glass out of his truck, and this is 2 weeks later. So people become so enmeshed in the actual event that they don't do the basic things of self-care that you would normally do. And when you do that, you can't really help people. So the emotional responses, again, continuing on, just heroic, euphoric feelings. It's a rush that people get, but then there's the other side of that rush, which is often depression and guilt. People may feel, why did I survive and somebody else did not? Why did my house survive when the one right next to it was destroyed? People also sometimes will be extremely apathetic, and you'll know that they could do the things they need to do to move forward, but they're not doing it. So then their loved ones get mad at them, and that's not a good reaction as well. And then there's the thinking or cognitive reactions people have, and this is setting priorities, loss of objectivity. I remember in Katrina, we'd see a lot of people spend an inordinate amount of time trying to find the family photographs in their destroyed home, which was very important to them, but it wasn't getting their basic needs met at that point in time. So again, an area where counseling will really help people is in helping recognize from their point of view what it is they really need, and then shifting them to what is most constructive for them to do in a very respectful and culturally responsive way. Okay, the behavioral reactions, again, you'll see a lot of this, change in activity level, reintroducing alcohol, difficulty in communicating, etc. And different feelings of frequent crying and difficulty sleeping, different job levels or job performance people having are all important items. And then spirituality is really important, to be respectful of how people feel about things from a spiritual point of view. And it won't always be positive. It will be that God has punished me and that's why this happened to me, or it'll be on the more resilient and optimistic side of God knows what's best for me and He's going to give me the strength to get through this. So it's something that you have to be very sensitive to and respectful to. Okay, and then we have the individual responses that are the most severe reactions, and these you can just see up there, a lot of anxiety and depression, acute stress disorders, substance use, and PTSD, which Linda's going to go into more detail about, dissociative disorders and paranoia and suicidal behavior. Okay, excuse me. The individual reaction, severity of the reaction is often associated with the level of exposure and the casualties that are associated with that disaster, the pre-existing trauma that may exist in people, and pre-existing levels of support that are available. You will see, as we talk further into this, about support and prior trauma exposure are going to be two of the major things to look for in people that you encounter, especially in shelters. We want staff, and this is why it's important for everybody to have this sort of overview of this information, so that not so everybody who works in a shelter can treat somebody with a severe reaction, but to recognize reactions and refer people to the appropriate specialists that are available either on call or working in the shelter with you. You'll see that this particular collective and community reactions heuristic device looks very similar to the one we looked at earlier, and they follow the same pattern pretty closely. Okay, and again, as we've spoken, there are typical phases of the disaster. There is the disaster that comes with no warning, and then there's the disaster that gives you warning like a hurricane would. Okay, and again, your same phases, which you can look at these at your leisure, but these are just at the community level, the same kind of phases that we were speaking of at the individual level. Okay, so just a summary of survivor reactions. Survivors should not be regarded as pathological, the reaction should not be regarded as pathological. You'll see sometimes people, because they have a history of a mental illness, they may be very stable within having had any symptoms. They could be responding with shock and having a response to the crisis itself that has nothing to do with mental illness, just being another person who's severely impacted by the disaster. The proper intervention there is not to treat the mental illness, but to treat the issues associated with the disaster. You'll also see people who, this will bring up old disasters that they've experienced. And again, that's previous trauma exposure, but it may not result in traumatic stress reaction. It may result in some other kinds of behaviors a person may experience. So it is important to provide assistance to people early on and identify if they need referral on to more professional level services. I think that, do we have any questions on that particular item from the audience at this time? If not, I'm going to turn it over to Linda.
Yeah. So at this point, we wanted to talk a little bit more about at-risk populations. Who are those folks who are most vulnerable? What places them at risk? What are some of the reactions we see? And what can we do in those situations? So I think we mentioned earlier the populations who are most at risk include children and youth, parents or caregivers of children. I mentioned earlier a single mom with a couple of children is really quite at risk. She's probably low income and has other factors that place her at risk. Maybe not having so much support. Older adults, people with prior trauma history, we mentioned that several times, people with serious mental illnesses, disabilities, history of substance abuse, low income groups, persons who are homeless, and we also need to remember that our public safety workers are also vulnerable because of the type of work that they're doing. So I don't want to go into all of these slides about children and youth, but we have many of those, and you can take a look at them. But some of the risk factors include separation from family. If children, of course, are separated from their family members for some reason during that disaster, that's going to place them at risk for adverse reactions. If they were involved in evacuation and relocation, it's very unsettling and would heighten anxiety. Loss of a family member or a close friend, particularly in a school situation where another child in the school may have been injured severely or or died in the case that Tony was talking about earlier, would certainly affect all of the children in that school or in that family. Where there are high levels of parental distress, there are going to be high levels of child distress. When parents are doing okay, children will do okay, and we have to really remember that and help the parents to really cope better so that their children will also cope better. Family members who are at risk, such as first responders, are also at risk. But some of the protective factors, so what are some of the areas that would help individuals, children, to be able to cope better? If there are strong relationships amongst family members, there's a good support system there. That's going to really protect that family and those children from adverse reactions. Strong relationships with extended family and friends. We saw after Katrina, particularly in Louisiana, how disrupted that was. I mean, people lived in neighborhoods where their extended family members and neighbors were very, very close to each other, where they supported each other, and when that was destroyed, people were evacuated, people were transported to other areas of the country. It was extremely disruptive, and really led to adverse reactions, including many physical health problems. You saw an amazing amount of deaths associated with Hurricane Katrina in the population affected in Louisiana. So, I mean, extraordinary stress related to not having those support systems. If there are relationships with healthcare, strong healthcare connection, that's a protective factor. Connection to church and school, and good health habits. Good health habits, we're talking about folks who are able to really cope with stress because they have these good health habits. Again, assessing children's needs, we start with Maslow's hierarchy of needs, making sure the kids are getting their very basic needs met first. And we're also going to look at the degree of exposure. We saw earlier the model that Tony showed about the degree of exposure being those who are most exposed or closest to the impact of the disaster are most at risk. So some of those typical reactions for kids include fear, anxiety, temper tantrums, sleep and appetite changes, and social withdrawal. It's a little bit hard to read this one, but and so, what are we going to see in kids? What kind of behaviors are we going to be looking for to show us that kids are having a reaction to that traumatic event? A lot of times children are going to complain about physical things like stomach aches, headaches, and they don't want to get up and go to school for that reason. And so not all parents are going to understand that that's a sign of stress and it's related to the disaster. So again, behavioral health workers, crisis counselors, really important to teach parents and caregivers that those are some of the signs of stress. If the child is withdrawn, having problems concentrating, school issues where they didn't have school issues before, or bullying types of issues, those are really signs of stress. Certainly we could see in kids signs, more serious signs of distress, which we would consider post-traumatic stress disorder, would include re-experiencing or avoiding the event, maybe the area where the event occurred. We would see some hyperarousal. And so, as I mentioned earlier, it's really important to teach parents and caregivers what's going on with kids. Because one of the things parents often do is they deny help for themselves. They say they're okay, but they'll accept it for their kids. And that's okay, because that's a way to get to the parents. Is to start where they're at and start with how their kids are doing and teach them about stress reactions and what they can do. And sometimes they are unaware of their own stress reactions. And of course, once you start to focus on the kids, you can certainly move into how the parents are doing, the kinds of supports they have. Are they connected to others? Are they connected to services and resources that they need? And some of the ways that adults can support children is to model calm behaviors. Maintaining routines is extremely important and reassuring to children, and helps to reduce anxiety. So when school reopens, because it may have been affected by the disaster, that's going to be a time when there's going to be some heightened anxiety at the beginning. But once the kids settle into their normal routine, that's going to really help to reduce anxiety. And it's the same for parents. Once they go back to work and to their normal activities, it's going to help them to reduce anxiety and manage and cope better. Engaging in fun activities is extremely important. You know, we may not think about that at the time of a disaster, and sometimes people say, how can I think about doing fun things when my neighbor just lost their house or something like that? But it is really important to help people to think about some ways that they could kind of get away from that stress of the situation and help their children to get away from that as well. What are some of the things that they enjoy doing as a family? Maybe it's playing games, maybe it's going to a movie, and that can be very helpful. Limiting media exposure, clearly when there's a disaster, there's extraordinary media coverage, and we have to help adults, particularly parents of kids, understand how frightening that is to children because they re-experience that trauma. And it's the same for the adults as well, and they may not realize how traumatic it is and how re-triggering that might be. So again, it's something that we need to teach folks about. You know, so here we're talking about supporting the parents who may also be traumatized, you know, making sure that they're less isolated and that they're connected to the resources they need, and it's important to help them to see how important their role is in relationship to their children. Older adults, I'm going to continue here to try to go through some of this more quickly, but we're also looking at another at-risk population, which are older adults. And some of the risk factors are they may have physical limitations, previous losses, dependence on medications. They may be also reluctant to accept help. Oftentimes they are. They're not used to getting help. And now, you know, this is a different situation for them, and they're not accepting of it. They've been independent all their lives, and it's difficult for them. And also they may be disconnected from social supports, from family members who can give them those supports. These are some additional risk factors. Of course, there could be poverty, mobility issues. And so again, it's important to think about what are those basic needs and make sure that those needs are met, and to consider the impact, the psychological and also the physical stress. In Louisiana during Hurricane Katrina, roughly 71% of survivors were older than 60, and 47% were over the age of 75. That's a huge percentage of people in that category. So thinking about them in terms of your planning for disasters and thinking about this population in terms of response activities is really important. Another category of folks who are at risk are people with prior mental health diagnoses. We have to remember that they're not people who are necessarily going to fall apart because there's a disaster. They're used to dealing with adverse events and experiences. Oftentimes they've experienced other traumas in their life. In their lives, and so oftentimes they're resilient, and oftentimes they have the same reactions that everyone else has to the disaster. They may not have an exacerbation of their symptoms. They may just be reacting normally to that abnormal event, and we have to remember that. Of course, they have the same basic needs as everybody else, and they have the capability of exhibiting heroic behaviors as well. I mentioned some of these already. People with, you know, of course, we're talking here about people with co-occurring disorders of substance abuse and mental health, people who might have mental health issues as well as physical disabilities. And some of those risk factors include feelings of increased vulnerability, trust issues, There may be a risk for developing PTSD, particularly when there was previous trauma exposure. And they may have been having difficulties before the disaster in terms of their illness and their symptoms. And of course, the disaster would just make that worse. Trauma, of course, the disaster trauma may trigger previous traumas. And so it's really important to ask folks, not just people with a mental health history, but anyone that you're working with may have been, and we're going to get to that in a moment, but they may have been exposed to trauma in the past. And people with mental health diagnoses, of course, may also be dealing with disconnection from families. Oftentimes we see that, particularly in the people with serious mental illness. And they're also dependent on community resources and supports. And so we have to consider them again when we're doing planning. Where are they located? What kinds of resources and supports will they need? And what if something happens to the mental health center in that community? How are we going to get them the help that they're dependent on? I really encourage you to take a look at these slides. I think there's a lot of information here. And we kept the slides wordy so that you could take a look at it and hopefully understand what it means. But people with prior trauma history have need, of course, for physical and emotional safety. They also, of course, have a need for tangible resources, just like everybody else. We have to consider, of course, that there may be a need in shelters for detox areas, quiet areas, particularly for people with prior mental health issues, a trauma history. You know, being in a noisy, crowded environment certainly can make someone feel unsafe. And that's the last thing we want. We want to really make sure that people do feel safe in order for them to start to recover. And allowing service dogs, of course, in a shelter situation is going to be extremely important. And a behavioral health person may be in a position to educate others in the shelter about that need. People with substance use disorders, they may be current users or they may be at risk for increased use or abuse. Stress and PTSD are known risk factors for substance abuse. We know that people who have trauma histories often use substances as a way of coping with the adverse experiences that they've encountered. And so even if they've been sober for a long time and now they re-experience a trauma, they may go back to some old patterns. And so we have to be aware and observant of those kinds of things and help people to get back to what was helpful to them in the past. For example, AA meetings. I think shelters sometimes have AA meetings right in the shelter, isn't that right?
They'll have that, or they'll have a list available.
In the community.
In the community.
Very, very important. People with disabilities, of course, evacuation may be more difficult. And, you know, here we're talking about shelters not being general needs. A general shelter may not be wheelchair accessible, and that may be a situation where that person may need to be in a medical special needs shelter. Homeless populations also are at increased risk for adverse reactions. They obviously have a lack of resources. They have a very high rate of pre-existing trauma and may also have signs of mental illness that may have been untreated. They may have a history of being untreated. They may have difficulty being in a crowded area, disconnected from their social supports. They may also, we learned when we looked at some of the scenarios that have occurred in Alabama, one of them was that it was difficult to get a couple of people who were homeless out of the shelter once the shelter was about to close. So there are all kinds of factors and issues that are important to figure out, particularly when you're planning, and to think about in terms of response activities.
Linda, are there guidelines in place to define what homeless really means as it relates to people migrating into a shelter?
Well, I guess I would kind of defer to what Tony was talking about earlier and say that you know, within your mental health, your behavioral health system, you probably have existing guidelines that kind of define for you what, you know, how to categorize folks who are homeless. And of course, they're the homeless population that was homeless prior to the disaster, and now there's a new homeless population of people who are left homeless because their homes were destroyed because of the disaster.
Right. I know several years ago, HUD redefined their definition of homeless, and I was just curious as to how that played into the role of the homeless person in the shelter.
If I may, that's those definitions for normal regulatory processes in government all go out the window when you introduce the definition of disasters as to alleviate human suffering.
Right.
And so it's important in the training, for especially when you're working with people who have delivered a lot of services under those regulatory items, to not hold too closely those definitions in the actual sheltering.
Right. Thank you.
So we mentioned earlier that public safety workers were also at risk for adverse reactions. And some of those risk factors include exposure. They may be exposed to the disaster event personally, and they're also, of course, exposed to it through their work. They may also be have the threat of injury or harm to them, to their physical being. They're also separated from their family members during this very stressful time, and those are the folks who they rely on for support. They view themselves as helpers and not someone who needs help. And so oftentimes it's very important to make that extra effort to reach out to public safety workers to ensure that they're getting the support and assistance they need. They also are dealing with a demanding work schedule. And so some of those causes of stress reactions are that they may be involved in life-threatening situations. And that's the most difficult. When someone perceives their life is being threatened, they are at highest risk for post-traumatic stress disorder. And we may see extreme fatigue and exposure, sleep deprivation. At this point, I wanted to move into, was I doing this section?
I can do this and go to the trauma.
Okay.
Okay. I think one of the things, what Linda was just speaking of about the public service workers, oftentimes we don't include our public health employees in that definition, and so it's really important if you're a public health worker to take to heart some of those stressors that are true of any public health worker, public safety worker. Hey, the recovery principles of response efforts and disaster resources. The first part is these basic principles of respect, empathy, cultural sensitivity, strengths focused, and empowerment. If you took those 5 bullets right there and just kept those in your toolkit when you're intervening with people, no matter what the level of work you're doing, you would be very successful. The treating people with dignity and respect, especially when they feel they've lost so much dignity and respect by losing everything they have, is really an important feature. Being transparent and being genuine. If you don't know the answer, you don't know how long the shelter's staying open, you don't know what's for dinner or when dinner is, say so. Be fully present and be curious. People just, especially like children, when they're in distress or you're not being genuine with them, they certainly can tell. But they certainly know a genuine effort of assistance. Even if it's not an efficient effort, if it's genuine, it's very helpful. There's a definition which I would really encourage you. It's a great definition of cultural responsiveness to read and just really spend some time on the words, what they mean, and what they mean in your workplace. Being culturally responsive is a lot about communication in nonverbal ways as well as verbal ways. So being aware of what's comfortable for people of other ethnic and racial backgrounds, closeness, distance, eye contact, a number of those things are nonverbal things that signs of your genuineness when you're interacting with someone. There's also cultural responsiveness. A feature of it is cultural humility, which is another way to understand and develop a process-oriented approach to competency. And what this is saying is that there's no way, and as you go through your life's journey, that you'll ever be quote-unquote culturally competent, being an end point, that being responsive to peoples of different cultures and backgrounds is a life occurring event that goes on just as much as breathing does. It's how you interact with people. And that responsiveness is not just a journey of excitement, but also improves your ability to provide services. Okay, so in cultural responsiveness, again, like I said, it's a lifelong commitment, and it is really a way of aspiring to develop partnerships with people and groups who advocate for others, knowing that we're all, especially in disasters, pulling in the same way. Again, on promoting resilience with others, especially when you keep a cultural-oriented framework, social support, coping, self-efficacy, and hope are some of your major areas. Being able to successfully connect with each other in a shelter situation, especially if you're from different cultures, provides a way of you finding practical ways to help and problem solve that people will accept. Or they wouldn't necessarily accept them if they didn't think you were very genuine in what you were doing. So some other things about promoting resilience is offering comfort to people and knowing that they're not alone, that they have a common set of issues and challenges facing them that other people have experienced and are there to also provide them assistance with. And on this particular side, if you look at that second bullet, when a person believes that they can cope with the results of a disaster, then they can and do recover. So belief and hope are two very important features of this. Hope here is defined as having a positive expectancy, a feeling of confidence that life and self are predictable, and that one can have a sense of optimism about the future. Now, getting there is a whole nother story. And as we move through that process, for some people it may take a very long time. They may be there in a week. Okay. Then some tips on promoting resilience. Having people make realistic plans, giving people some action they can actually do, reestablishes a sense of power and a sense of capability. Maintaining a positive self-image and confidence in one's own abilities, and utilizing effective communication skills. Those are really ways where you can promote resilience. Managing emotions, making connections with people, maintaining a hopeful outlook, and practicing effective self-care. Now, in the psychological first aid, I know a number of you have had these experiences, and I want to of training in psychological first aid. It's not just for people who are trained behavioral health professionals, but it is designed in a very nice way for it to be used by people in a number of different disciplines and work, providing different levels of work in a disaster. These, to me, are the main points: contact and engagement. Making that effort to contact people in a non-intrusive and compassionate way, safety and comfort, making from the person's point of view you're trying to help that they're safe, not from your point of view, stabilization, calming people, information gathering, getting information from an individual of what they need so you can help them in areas that they need assistance. The assistance is practical, and they're connected with families I know the social support systems, they're giving information on how they can cope themselves, and they're linked to continuing services. I'm going to skip through these at this point so that you can spend some time in a more detailed way, especially if you've been through the PFA training, to go through this process. At the end of this section, there is a
Mobile app.
mobile app. It's on the PFA website, and you can download it for your device, no matter what kind of device you have. And it has great ABCs of how to help yourself with this information and also provide assistance to others. Moving to just some of the basic crisis counseling issues. This is not therapy when you're doing interventions in shelters or the other settings we've mentioned. It's short term. It's based on the very near future. It builds strengths, and it focuses on healthy coping. Some of the techniques that are listed here are very much of a cognitive behavioral type of looking at very practical ways at people and affirming where they are and what they can and can't do. Please look at these and think about how you can put these skills to use as you use your psychological first aid skills. And Linda, you want to talk about trauma-informed care?
Sure, sure. So what we're talking about here are ways of that people who are engaged in the response activities, kind of the skills and the preparation that they could use. So we talked about people can get training in psychological first aid, people could get training in basic crisis counseling skills, and here we're talking about trauma-informed care. And we really want to start with a definition of what is trauma. And certainly we've mentioned earlier, it refers to intense, overwhelming experiences that involve serious loss, threat, or harm to a person's physical or emotional well-being. And trauma can occur at any time in a person's life. And it may involve a single traumatic event or an event that was repeated over a period of time. Trauma experiences generally overwhelm the person's ability to cope, and really in most situations, or in a number of situations, people find ways to cope or adapt to these adverse experiences that in the short run may help, like turning to alcohol, or drugs. But then, of course, in the long run, it just complicates the situation and causes them more problems. Some of the symptoms we see of trauma include irritability, anger, self-blame, isolation, fear, feeling stunned, numb, helpless, and hopeless. Some people exhibit mood swings, sadness, poor concentration, and this is why I talked earlier about, really needing to be very direct with someone who's experienced some kind of a disaster situation, who may also have previous trauma or may even not have previous trauma. But the brain is affected by that traumatic experience that they just experienced, and their cognitive process is affected. That area of the brain is affected, and so their ability to concentrate. It's just like when we go to the doctor and we get a serious diagnosis, what happens? We don't hear anything else that the doctor tells us after that, which is why it's always important for us to bring someone with us. And we can't, because we can't think clearly. We're overwhelmed now by the information that was shared, by the emotional reaction that we have. And it's the same for people who are in a disaster situation. Of course, multiple traumas increase risk, and there's also risk additional risk for smoking, suicide attempts. It is really important to consider issues around suicide when you're in a shelter or a disaster situation, particularly if the person does have a history of trauma. There is, or a history of serious mental illness. They may be at higher risk for suicide, and so it's really going to be important to do those assessments and be curious and ask those questions, and make sure that the person has the kind of supports and connections they need in order to cope. So we talk about trauma-informed care. Being trauma-informed really is about realizing how trauma affects people. What is the impact trauma has on people? What are the signs and symptoms of trauma? Responding to that person in a way that you're really viewing everything through a trauma-informed lens, and maybe giving up some of the old practices and adopting some new practices. And certainly it's about resisting re-traumatization by addressing trauma issues and reducing stress. These are definitions that were developed by an expert panel that SAMHSA put together. Some of those principles of a trauma-informed approach, Tony mentioned earlier some very basic principles and practices, and those are really embedded here as well. Safety. People can't begin to heal unless they feel safe. And that's the case after a disaster situation. That's the case for people we may be seeing in our practices or in our mental health agencies. People need to feel safe in order to heal. There needs to be a trusting relationship. Peer support is extremely important. So getting consumers involved and having peers involved in providing that support is really critical. So for example, in the case of public safety workers, in New York after 9/11 and in Louisiana, actually folks from the public safety workers, the fire department folks that responded after 9/11 actually went to Louisiana after Katrina to work closely with them to talk about what worked in New York after that serious disaster. What do public safety workers need? Remember, we talked about them being the helpers. They're not good about getting the help. So who's best to reach out to them? Other people from the fire department or the police department or emergency management. Those are the people they could relate to best and who would understand them. Trauma-informed approaches is about collaboration and mutuality with the person you're working with. Remember, we talked about power imbalances. We shouldn't have power imbalances. We need to work in a collaborative way. Trauma is about loss and loss of control, and so empowerment, giving people a voice and choice is going to be very important. Helping them to make decisions and their own plans and following up with their next steps is a way of empowering folks. Also, a part of being trauma-informed is, as Tony mentioned earlier, looking at issues around culture, historical traumas, gender differentials, and it's really all about looking at yourself as well as asking questions of the person so you could understand, because two people from I have Italian background, I may have a very different response than someone else who has an Italian background. And so we really need to get to know individuals and what their customs, beliefs, and values are. So being trauma-informed is about promoting physical and emotional safety. It's about practices that help to create that safe kind of environment by providing consistency, predictability, respect. Using interventions that are specific to cultural backgrounds, really understanding the folks that we're working with, making sure that if there's people who don't speak English, that we're getting translators involved, that we have materials and literature that people can understand. I wanted to include this. It's SAMHSA recently came out with a resource which is called Trauma-Informed Care Tip. They have a number of tips, and this can be found at the SAMHSA publication site. And the one that came out recently is called TIP 57 and is Trauma-Informed Care in Behavioral Health Services. Understanding trauma-informed care is extremely critical to any work that we're doing, because it's just a way of being with people that's going to promote healing and recovery from whatever someone has experienced, whatever the trauma might be. So I encourage folks to take a look at this, and you can order it for free from the SAMHSA Publications work website. Mental health first aid is different from psychological first aid. Mental health first aid is a way of teaching people who are not professionals in the field of mental health, how to recognize signs and symptoms of mental health issues as well as substance abuse issues and trauma. So it's a very basic training. And a training like this, for example, could be very helpful to public safety workers. What are you, or to shelter folks who are not trained as behavioral health professionals? What might they observe? We talked earlier about them being, it's really how important it is for them to observe people's signs and symptoms in terms of their behaviors. Well, taking a course on mental health first aid would really expose people to what am I looking for, and what do those signs and symptoms relate to? Is it depression? Is it anxiety? Could it be bipolar disorder? And once I see those kinds of signs and symptoms, this course really helps people to know, what can I do? And this is a wonderful course for lay people in the community as well. So for example, after a disaster, it's really important that the community come together and they have a sense of what are some of those psychological reactions people may be having in the community. This is really a way of exposing even the general population to what signs and symptoms might occur after a disaster trauma. I'm not going to go into all of these. I would like to share with you some of the local resources. Tony had mentioned earlier voluntary organizations active in disasters. There are many organizations that come into a community after a disaster. Lutheran Social Services is an example, Catholic Charities. It's going to be very important to get familiar with all of those resources that are now springing up in your community, because you want to be able to know exactly what they're doing so that you can match the people's needs to the resources that are going to be most helpful to them. Alabama has a state VOAD, and you could go to their website and see what kinds of resources they have there. Some of the national disaster resources include the SAMHSA's Disaster Technical Assistance Center. It's called DTAC. They have an incredible amount of information, tip sheets for children, talking to parents, all different types of disasters. I encourage you to go to their website and take a look. SAMHSA has also a disaster distress helpline, which was very helpful in the after the oil spill and many other disasters. It's really a good resource to give to people in shelters, because once the shelter closes, here is a number you can call if you start to feel anxious or distressed. SAMHSA also gets funded by FEMA to provide funding to the states and localities to have a crisis counseling program after a disaster, and that's really our nation's way of responding to the emotional and psychological reactions to a disaster. Oftentimes, there's a disaster case management that states or local organizations will apply for as well through FEMA and the ACF, children,
It's children and families.
it's children and families. So anyway.
Administration. for children and
Administration
families.
on Children and Families, that is a federal agency as well as FEMA, and they actually monitor the disaster case management program that some states and local organizations apply for after a disaster. Some other resources include the ASPR, which is the Assistant Secretary for Preparedness and Response, Centers for Disease Control. FEMA has an Office of Disability Integration and Coordination that you should know about. Of course, American Red Cross, American Psychological Association. The National Child Traumatic Stress Network, I really encourage people to go to their website. They have amazing resources around children and trauma. They're also developed psychological first aid, and you can get that phone app at their website and get online psychological first aid training as well. There's the National Center for Post-Traumatic Stress Disorder and there's a staff resilience phone app too. And now I wanted to turn it over to Tony to talk about self-care.
Thank you, Linda.
Critical.
And early on, I mentioned that without healthy responders, our ability to provide services is very limited. It's also as I'm sure you all have spoken in this state, the people who come to work every day delivering services are then expected to go into a disaster response role and then show up the next day to work like nothing ever happened. And that can be very stressful on people. So there are a few tips of the trade here where that process can be mitigated both organizationally and also personally. The basic top 3 items here is plan for self and family. If you do not have an emergency preparedness plan for your family, then go home today, go to this app for the Red Cross, and go to this website for the Red Cross, and they have all kinds of activities that your family can engage in to assess your own readiness for your family, and then also for you as a responder. If you have, for instance, say you have just experienced some unpleasantness in your life, and a parent has passed on or something like that, you may not be emotionally ready to provide this kind of assistance, and you need to communicate that to your supervisor. That now's not the time for you to carry that kind of work. There's also a concept of compassion fatigue, which speaks to caregivers starting to carry some of the weight of the trauma that people have been exposed to that they've helped them with. Be aware of that. Again, there's some excellent articles on it that are short that if you go online and look, you'll find some very good techniques and an awareness of setting some boundary conditions for yourself. And then the response team and their well-being. Knowing the symptoms of disaster trauma will help in learning to manage stress. There's a lot of techniques, which we've given you many examples of, about managing stress. But if you go and you talk to a bunch of EMS workers and ask them how they manage stress, they'll tell you some wonderful things that may not be self-evident to you, and they don't all involve alcohol. They involve positive things that people do for themselves and their families. So the definition of stress you all have heard multiple times. Again, look at how this is written, especially where an optimal, look at the last bullet here, an optimal level can act as a motivational force. So there's a whole concept of eustress and distress. And positive stress is what you want your football team to have, optimized ready to perform at their finest when they go into that difficult situation of playing a football game. Too much stress, though, is distress, and then that gets in the way of performance. These are, again, some of the things you'll hear. The ability, stressors are things that you'll hear a lot of first responders say, their ability to help others. They feel so helpless. They can't give what is really needed. Again, the working long hours and the personal experience. And I don't know if I have it in these slides, but there's this whole concept of two allegiances or two families. My worker family of the firehouse or my unit as a police officer, and also my individual personal family. Those are things that have to be taken into account as you're building a response plan for yourself. Again, these are some of the same physical signs we've looked at before. We've mentioned a number of ways to reduce stress. Exercise, I'm a big fan of, and eating carrots instead of other things with too much corn syrup in them are often a good plan. And then also explaining to family members what you need. And, you know, we have a number of ways that we've mentioned that, and certainly would respond to any questions people would have along that line. The important thing is for team leaders to also recognize that the job is not just getting the job done, but also keeping your team healthy. So team is a concept that's really strong here to help mitigate a number of these stressful situations that people find themselves in. So I'm going to stop there, and Linda, you want to give our key messages?
Yeah, we've just said a lot to you today. We've covered a lot of material, a lot of information, and we wanted to just leave you with kind of a summary of what we thought were the key messages. Disaster trauma is about loss and disempowerment. Healing happens within relationships. Building resilience begins with the first encounter. So every single encounter you have with someone is really important. It's an opportunity to build resilience. Resilience requires safety, connectedness with others, with resources, empowerment, and hope. You actually are the tool that assists with healing and promoting resilience. So it's really use of yourself that is, you know, in that relationship and that empathy and compassion that you bring to this work that's going to begin that healing process. It's that active listening, that connecting with that person. It's the curiosity that's really going to begin that healing process and help that person on their road to recovery. And of course, we want to leave you with the message to remember to take care of yourself. Thank you so much.
Thank you so much, Linda and Tony. What a wealth of information that you've shared with us today, and we really appreciate all the information, especially as it relates to the different principles of disaster response, because we're often encouraged to make sure that we maintain that respect, that empathy, and cultural sensitivity, as well as treating people with that dignity and respect. And you did a really good job of emphasizing that throughout the course of this discussion. As we begin to close and wrap up, we have so many public service workers who are viewing this program, but also that we partner with through the Alabama Department of Public Health, as well as the Department of Mental Health, and a number of other state agencies, community organizations, and faith-based groups. What closing tips can you provide that you can possibly share with the different groups who are likely to serve as responders during a disaster?
I think the words that come to my mind actually are that we are all human, you know, and we have reactions. It's just normal to have, as you know, as we started out this conversation today, we talked about, you know, it's really normal to have reactions to disaster stress. And public safety workers are not immune to that stress. Or to those, to those reactions. So I think that, it's really important to remember that. It's really important to, remember to connect with family. The family, your personal family, as well as your work family, because we know how important those supports are really in coping, and to not work too many hours. That's really critical as well. And maybe you have some additional.
Well, those are wonderful. People carry out those; they'll be much better off. And the one I would leave you with is find a buddy. Oftentimes, your colleagues you're used to relating to may not be at the same workstation you're at. So find a buddy and say, "Look, I'm going to give you permission to tell me when I've had enough." And do that when it's before they have enough time, when everybody's still calm, because then what you find is when Elena reaches over and goes, "Tony, time to go outside and drink a cold drink." Or all she has to say is, "Tony," then I know she's taking care of me. And that's really important to have that buddy, and then you get to do that same thing for the other half of that.
I think that's excellent.
Taking care of yourself, that is so important. Thank you so much, Linda and Tony. We appreciate the National Council for Behavioral Health for loaning Linda to us, and we appreciate Tony for taking a couple of days out of his retirement.
Yes.
He is recently retired and has chosen to come and spend time with us to share this information with individuals who are interested in learning more about this program. And also we appreciate our partners, our planning partners with the Department of Mental Health, who has assisted significantly in coordinating this program as well. Our next emergency preparedness training program is scheduled for Wednesday, June 18th from 9 a.m. until 10 a.m. The title is The Human Side of Disasters, the People Behind the Faces. For updates on that program as well as other future programs, please visit the website listed on your screen. This concludes today's program. Thank you for joining us and have a great day.